All right, so I'm gonna walk you through this first question that I've got for you guys. The way I like to do my questions is I like to integrate from step 1 all the way to step 3 because I think it really helps to understand the pathophysiology, the physiology, the management, and then potentially next steps that step 3 could ask you. I think if you become a master of all of this, you can pretty much ace any of these exams and you'll be well off for the clinic. I think if you're getting ready to take step 1, looking at the step 2 and step 3 management tips are only going to help you, and then we'll prepare you further on. And let's say you're getting ready for step 2 or step 3, if you refresh yourself on the pathophysiology, it makes the diagnostics and the management much easier. The way I approach everything is I always like to ask myself why. I like to ask myself why until I can't anymore. If I understand the why, I'm going to understand everything we're doing. So, and we'll make integrations as we go here. So we have a 64-year-old woman. She has chronic alcohol use. She's admitted for confusion, weakness, and poor oral intake. She was recently started on furosemide for ascites, but she remains disoriented despite potassium repletion. On exam, we note asterixis, disorientation, and leg weakness without focal deficits. We see her potassium's pretty low, her magnesium's low, her ammonia's high. We see her MCV's pretty elevated, her platelets are a little bit low, hemoglobin's low. Her AST to ALT has a nice little 2-to-1 ratio there. Her albumin's a little bit low, her INR is elevated, and her creatinine's normal. So when I take a look at this, right, I see a little bit older woman. She's got the chronic alcohol use. She's got the classic over 1.5 to 2-to-1 ratio of AST to ALT. I'm pretty much assuming this is going to be alcoholic cirrhosis, right? So with this, we have to understand why is she having confusion, right? I'm going to do a whole lecture on delirium or encephalopathy because I feel that deserves its whole lecture. But really simply, you can break it down into this MIST kind of mnemonic. So the M stands for metabolic, the I is infection, the S is structural, and the T is toxin. I think when you look at this, right, we have a pretty good idea of kind of what's going on, right? This is likely going to be hepatic encephalopathy. It's our job to figure out why, right? So hepatic encephalopathy is going to be due to an increased ammonia, and we're going to talk through that pathway pretty soon here, but that would kind of fall in the metabolic section, right? But we could consider infectious, we can consider structural or toxic as well. And again, I'll do a whole lecture on delirium and encephalopathy so we can break down that framework even further and dive deep, right? So now that we have an idea, okay, this is hepatic encephalopathy, we can move to the step 1 question. I want to also just bring up, sometimes they won't give you the AST, ALT, or they'll talk about what other lab tests could we run that would tell me this patient likely has alcohol abuse. One of them is GGT. So an elevated GGT is a good marker of alcohol use. And the even better one is something called carbohydrate deficient transferrin. And probably some of you have never heard about that. It is the best test we have. If we wanted to do like a single lab test, it would be carbohydrate deficient transferrin. If that's elevated, that tells me the patient has alcohol abuse. So those would be like high yield points if you want to get some extra points on maybe like step 2, step 3. So when we break down the step 1 question, we're asking why is the patient's potassium not correcting with repletion, and what's the pathophysiological mechanism behind her confusion and mental status changes. So I think we should tackle the second part first. So this patient has hepatic encephalopathy, but why? She has it because she has low potassium, and we're going to try to understand why that is causing hepatic encephalopathy. So when you have a patient who has liver damage, especially cirrhosis, right, your urea cycle gets damaged. Remember, that's in the liver. When your urea cycle gets damaged, we usually take ammonia, we break it down to the urea, and that gets peed out, right? But now my urea cycle is damaged, so the ammonia is not able to be effectively broken down into urea, and then ammonia starts building and building and building. Now, this patient was recently started on furosemide, but we didn't put on a potassium-sparing diuretic, and we'll talk about that in step 2 and step 3 land, why that's important. Remember, furosemide blocks the sodium-potassium 2-chloride channel, and it's going to cause us to pee out some of this potassium. We didn't put on a potassium-sparing diuretic, so we don't get that potassium-saving capabilities. So part of that is going to lead to low potassium. When you have low potassium, right, we already have the buildup of ammonia happening from the liver. The low potassium also is going to play a role in the kidneys and the gut. So let's start with the kidneys first. Our tubular cells are going to sense that there's a low level of extracellular potassium. What they're going to do is they're going to throw potassium out. And remember, potassium is a positively charged cation. So is hydrogen, right? Potassium and hydrogen are linked, right? We know that they're linked in the kidney, and we also know, remember, the parietal cells in the gut have this hydrogen-potassium exchanger. So our renal tubular cells are going to pump potassium out into the extracellular space, And for every potassium, we gotta throw a hydrogen intracellular. And so what's gonna happen there is the hydrogen being intracellular, it's gonna cause an intracellular acidosis. And that's gonna stimulate this glutaminase enzyme. And that's gonna stimulate the production of glutamine, and glutamine is gonna end up getting converted into ammonia. And our ammonia starts building, right? So our kidneys are gonna compensate, they're gonna keep potassium, throw hydrogen into the cell, and that downstream effect of throwing hydrogen into the cell is going to lead to an increased ammonia via glutamine metabolism. So there's number one. And number two is now we have lower hydrogen in our body, right? We're now starting to get into a metabolic acidotic state. Remember, in my gut, we have a lot of ammonia, right? That ammonia is being made by a lot of our gut bacteria. And normally our body is able to compensate. It's able to throw a hydrogen onto that ammonia, make ammonium, and then we can just poop that out, right? It's gonna be non-absorbable, we just poop it out. In this case, we have low total hydrogen that we're able to use, so there's less hydrogen that's able to be thrown onto that ammonia, and more of that ammonia gets made, and more of that ammonia gets absorbed, right? So ammonia, remember, is NH3, ammonium is NH4. So we have those three mechanisms there. One, ammonia is not able to be broken down into urea in the liver. Two, in the kidney, we're throwing potassium extracellular, throwing hydrogen intracellular. That hydrogen being intracellular upregulates glutamine metabolism. We throw that and turn it into ammonia. And then step three is in the gut. We have less hydrogen that's able to be used, less hydrogen able to be thrown onto ammonia, and less being turned into ammonium. And so more ammonia is getting absorbed. And then that ammonia can make its way through the brain. It's going to be permeable through the blood-brain barrier. And that can then be turned into glutamine. And glutamine will then cause osmotic swelling in the astrocytes, which can lead to our encephalopathy. And then the next question for the step one is, why is the patient's potassium not correcting with repletion? This is like almost buzzword heaven right here. If you ever see a patient's potassium that's not correcting with repletion, you should always check the magnesium. In this case, I gave you the magnesium on MBME questions. They might not. A patient who has chronic alcohol use is usually deficient in magnesium. We have poor magnesium handling, and they might also be on kind of more of like a tea and toast diet, an alcohol and toast diet, and they're not getting magnesium-rich foods. Magnesium is really important to inhibit the ROMK channel in the renal tubular system. And in this case, because we're not inhibiting it, we're able to pump more potassium out and pee it out. Magnesium is also really important to activate your sodium-potassium ATPase channel. This throws off that whole rhythm, and it also leads to losing of potassium. So two mechanisms there. The classic MBME question is you have a patient with potassium, low potassium. We try to replete it. It doesn't replete. They'll ask you what your next best step is. It will either be check their magnesium or replete their magnesium. Look for this in a chronic alcoholic. Our step two question would be, what would be the next best step for this patient's management? What would you expect to happen if you corrected the potassium alone? So again, the next best step in the management of this patient's condition should be to, one, correct the potassium, but two, we need to initiate the standard of care, which is going to be lactulose, which is a standard of care for the treatment of hepatic encephalopathy. We usually start with 25 milligrams orally. We try to titrate up so the patient gets 2 to 3 bowel movements per day. Remember, lactulose is going to acidify the gut lumen. We're going to be able to turn that ammonia into ammonium and poop it out. That will lower our ammonia level. Our step three question then is going to go one step further. What if our patient fails at lactulose and potassium replacement? What is the next best step in management? So to answer that first, if lactulose fails, we're going to throw on rifaximin. Rifaximin is an old antibiotic that will kill some of those gut bacteria that are making the ammonia in the first place. We usually start with 550 milligrams twice daily. Okay. How could this clinical picture have been prevented at the time of our admission? Well, if we start furosemide, we should have started spironolactone or eplerenone first. When we think about a patient who has chronic liver disease, there's a couple mechanisms by which the patient can get ascites. One, her albumin is pretty low. Remember, the three mechanisms of edema are low oncotic pressure, high hydrostatic pressure, and increased vascular permeability. She has low oncotic pressure. That's going to cause third spacing of fluid into the interstitium because there's less protein drawing water into the intravascular system. Also in cirrhosis or any kind of liver damage, we get backup of fluid into the portal system, causing portal hypertension. Ultimately, this can lead to sphincteric vasodilation. The liver is unable to metabolize nitric oxide. It leads to dilation of all of my sphincteric vessels, and overall a decreased effective arterial blood volume. So there's a decreased forward flow of blood. When there's a decreased forward flow of blood, there's a decreased forward flow to the kidney. The three things that activate my renin-angiotensin system are low forward flow of blood, low sodium chloride, and increased sympathetic nervous system activation through the beta-1 receptors on the JG cells. So in this case, we have low forward flow. The renin-angiotensin system goes crazy. Aldosterone does its thing. It keeps sodium in water. It pumps out H+ and potassium. And what's going to happen is we're going to retain all this sodium in water, and it's just going to keep getting third spaced. And this patient is going to have massive ascites. In this case, we can initiate furosemide. Furosemide will kind of decrease some of that intracellular fluid. It also has vasodilation capabilities, so it'll increase preload and hopefully get the patient's effective arterial blood volume back to normal. The problem of giving furosemide by itself, furosemide activates the sodium or it blocks the sodium potassium 2 chloride channel in the thick ascending limb, and that can lead to a lot of potassium wasting. So if we give a drug like spironolactone or eplerenone, which are mineralocorticoid receptor antagonists, that's going to stop that whole process, and we'll hold on to more of that potassium, and we hopefully won't get into this hepatic encephalopathy type picture we saw here. Remember the difference between spironolactone and eplerenone? They work almost about the same. Spironolactone has that extra anti-adrenergic capabilities. Eplerenone doesn't. There's also a newer drug called finerenone, which you might see coming up sooner or later. So there's that for step 3. And then our integration question is, why does the patient have thrombocytopenia? Let's start there. The patient has thrombocytopenia likely for 2 reasons. One is when the patient has portal hypotension, it causes my spleen to get enlarged. You've seen on a million questions, hepatosplenomegaly, right? The patient has a large spleen, guess what? It's going to eat up our platelets, right? The spleen loves platelets. Platelets get stuck in that splenic vasculature, the cords of Billroth, and they get stuck in there, and that's going to lead to low platelet levels. Also in this patient, when you have liver damage, we damage our thrombopoietin, right? Thrombopoietin is like the equivalent to erythropoietin made in the kidneys, except it's going to stimulate megakaryocyte production and the maturation of platelets. So we have low thrombopoietin, increased portal hypertension and splenomegaly, both leading to low platelets. The patient has macrocytic anemia, likely for 2 reasons. When I think about macrocytic anemia, right, that's an MCV over 100. We can break it down into megaloblastic and non-megaloblastic anemia. Megaloblastic anemia at its core is a problem with DNA synthesis. We can simply break it down into likely B12 deficiency, folate deficiency, copper deficiency, and then drugs that work on the bone marrow. A classic example would be like hydroxyurea in sickle cell. So alcohol itself messes with folic acid metabolism. So this patient could have folic acid deficiency. Again, if they're not eating a full diet of fruits or vegetables, right, they could also have low folate. You can become folate deficient in just a couple months. Remember, B12 takes many months to years. I'll do a whole lecture on anemia coming up. Another reason, though, is non-megaloblastic anemia. That's a problem with your membrane. So that can be further broken down into liver disease, alcohol, reticulocytosis, so just increased reticulocytes, and myelodysplasia, right? So this patient has liver disease and they have alcohol. So they have alcohol use. So really, it's probably a mixture of both megaloblastic and non-megaloblastic. We should do a peripheral smear, and we could see if we see the hypersegmented neutrophils, we might lean more towards the megaloblastic. Really, at this point, it doesn't really matter. We're going to need to probably replenish their folate, and then hopefully help the patient cut down on their alcohol use. The last question I have for you is, which IV fluid should be used for initial resuscitation in this patient? Lactated ringers are 0.9% saline. And you're probably thinking, these are both isotonic solutions, right? They could both be used for fluid resuscitation. And this is where a really fine point comes in. Lactated ringers should be avoided in this patient. Lactated ringers is made of sodium and lactate combined together. That makes its way to the liver. It gets converted down into bicarbonate, and then it can be used as a buffer. Unfortunately, in this patient with underlying liver damage, that lactate is not going to be effectively converted into bicarb, and that lactate could build up, and that could cause us problems in the future. Normal saline has problems on its own, right? If I give too much normal saline, right, its sodium chloride load is 154 millimoles. That's pretty close to our normal sodium level of like 135 to 145, but our normal chloride is like 100. So that's a huge chloride bolus. And when I give a huge chloride bolus, chloride's negatively charged, bicarb's negatively charged. If I have too much chloride, we're going to lose our bicarb to maintain electrical neutrality, and the patient can develop hyperchloremic metabolic acidosis. However, normal saline, 0.9%, is the appropriate choice, probably in this patient with underlying liver disease, because giving lactated ringers could cause elevated lactate levels. So this was a lot. I'll keep giving out more videos here and there, Let me know if you have any suggestions on other things I should cover. This is a really high yield concept. We covered a lot in under 15 minutes, so let me know what you think.